And it's 8 o'clock, so we'll get started. Welcome everyone to the Department of Medicine Grand Rounds. My name is Dinesh Kalra, and it's my honor today to introduce Dr. Kim Williams, who has been an amazing friend, mentor, boss for the past decade that I've known him. And it's a real honor to introduce him today to give Department of Medicine Grand Rounds. But having said that, Dr. Williams really needs no introduction to all of you and to the cardiology community in general. But I'll try to condense all of the remarkable things he's done and his spectacular career in a couple of minutes. So Dr. Williams attended medical school at the University of Chicago, followed by a residency in medicine at Emory University in Atlanta. And then he moved to Chicago to do his cardiology fellowship at the University of Chicago, where he served as faculty for several years, went on to head the nuclear cardiology laboratory, and then was recruited to Wayne State in Detroit to serve as chief of cardiology, and then moved back to Chicago to become chief of cardiology at Rush, where he was a James Herrick professor, and also served as associate dean for faculty DEI. And that's where I really got to know him very well and was impressed not only by his breadth of knowledge, but his kindness and his mentorship and his willingness to support all young faculty who needed him. So it's really amazing that then we were able to get him here a few years ago, as you know, and it's just been tremendous since that time. Dr. Williams has held numerous leadership positions and prominent roles, including having served as the president of the American College of Cardiology in 2015. And he was also the founding member and president of ASNC, which is American Society of Nuclear Cardiology, in 2004. As I mentioned, we were able to very fortunately have him join us as chair of medicine in 2022. And in that relatively short span of time, the Department of Medicine has seen tremendous advances in growth, as well as expansion of our missions and really the clinical area, research area, and education. And I'm sure most of you have experienced firsthand his passion for cardiovascular disease prevention, healthy eating, as well as advocacy. And he's renowned world over as the vegan cardiologist because he really believes and promotes plant-based nutrition as a way to reduce healthcare disparities as well as improve healthcare. He's a prolific academician. He has over 300 papers, multiple book chapters, and he serves as the editor-in-chief of the International Journal of Disease Reversal and Prevention. And he's contributed to many important guidelines in cardiology, including in the field of nuclear cardiology, hypertension, and now the preoperative guidelines for non-cardiac surgery, which was just published last week. So it is really timely that he's going to educate us today on that topic. So without further ado, Dr. Williams.
Thank you, Dr. Kalra. And I'm going to spend most of the first part talking about the state of the department, but it's really just an opportunity to say thank you to all the faculty, people who have been recruited, people who have come for leadership, and the people who were existing in leadership who have been really tremendous. Couldn't have done much of any of the things that I'll talk about for a few minutes before doing the guidelines. Why am I doing this? Apparently, this was the way the opening of Grand Rounds was supposed to be, the state of the department by the chair. So I'll just take a few minutes and do it. I didn't do it the first year because I had just gotten here and I had to talk about plant-based nutrition. And last year we talked about AI and the importance of that and incorporation into what we do. But the state of the department is good. It's actually excellent. We have a wonderful set of faculty and staff who help us every day to help our patients. And so if I were to do a catchphrase, everybody knows I like catchphrases and alliterations, it would be turning our attention to more prevention. Okay, so just a shout out to the leadership, ACCHA Guideline Committee. This was really tour de force every Wednesday for a year and a half, going through data to try to get this document in order and get it past everyone. So we start off with some definitions about the really important stuff. What is an emergent surgery versus urgent, time sensitive? I won't spend a lot of time talking about it, but you have the slides that you hopefully everyone will be able to come and grab and download to try to make sure that we are all on the same page, because urgent and emergent surgery is really important. We also have this concept of whether a surgery is low or high risk. And that is classically, this is pulled out of a different document. A high-risk surgery would be greater than 5% major adverse cardiac events or mortality. And that's typically your vascular procedures or any really urgent or emergent procedure. Then you've got the intermediate risk and the low risk. Don't have to remember this as much as we used to in the past. And that's because we were going to use scoring systems, and that's a class 1 recommendation. I usually don't, when talking about guidelines, have to show this because everybody's seen it, but you might not have seen what's at the bottom, which is that class 3 now has 2 different colors. Okay, that is red, which means class 3 harm, and a dark orange, which is class 3 no benefit. One of the most important things that we're trying to do is to use calculators. And pretty much when I'm on the wards, our folks are using the calculators pretty well. It is an important recommendation for people with known cardiovascular disease. Using a risk prediction score is really important. I won't go through each one of them, obviously, but there are 7 of them that are out there. There's data in the guidelines telling you what the advantages or disadvantages are. But I'm just going to summarize it like this. And you'll see American Society of Nuclear Cardiology at the bottom of some of these slides, because I was actually the ASNC rep on the committee. And so the revised cardiac risk index for preoperative risk estimation, that's the RCRI, is probably the most commonly used. But the important 3 bullets at the bottom here is that there are no comparative data to prefer one over the other. There are very few studies of altering strategies and having successful or better outcome just because one has used a prediction tool. But it's probably best used to try to figure out who's at extremely low risk. And that's the thing that really and doesn't need any further preoperative evaluation. We talk in the document about functional capacity assessment, which is really important. And not everybody has used the DAISY index, and that is the Duke Activity Status Index. That's a recommendation of something we should do. A quick summary of DAISY is shown here. You talk about the activity that the person is able to do, and you score them yes or no, and you add up the points. And so things like walking, self-care, climbing stairs, running, doing housework, doing yard work, and participating in strenuous sports. And obviously, you know that, tennis, if you're doing a lot of unforced errors, this may not be very aerobic, but if you're playing well, it's so there's some error and there's some historical or variability, but it's actually pretty tried and true. If you take this information, which may be totally subjective and slightly qualitative, turning it into a quantitative scale, you actually do see a scale that you can use to estimate the functional capacity of the patient. And so how do you get from the points where you add them all up to the METs? Is a formula that estimates VO2 max as maximum oxygen consumption. And you plug it into the formula and the calculator will do that for you, and that helps you. But putting it into METs probably isn't as helpful as using the DAISY score itself. If the person has a less than 35 score, that person is at a high risk of perioperative myocardial infarction, injury, moderate to severe complications, or a new disability. Now, that sort of pushes us into discussing frailty, because this is something that is being increasingly recognized as a problem for people who are undergoing non-cardiac surgery. So people should be evaluated. So how do you do that? There are multiple scores. I won't go through them all. Won't go through them all, but frailty predicts the bad outcome. And if you add up 56 studies of frailty, which was done by Girtis, and published a few years ago. Frailty is associated with a tripling to quadrupling of 30-day mortality, complications. So it's important to assess and when you're doing the consult, let the surgeons and anesthesia know that this is a problem if they're not aware of it already. One of the newer features is the idea of using biomarkers. And so BNP and pro-BNP and troponin, cardiac troponin, actually there is data that we can use them because they can actually predict postoperative death or non-fatal myocardial infarction at 30 or 180 days. And you actually may be able to predict pre-op risk using the high sensitivity C-reactive protein, but it's a relatively small amount of data that is saying that. Now, one of the more controversial areas, as a born and bred nuclear cardiologist, running a lab for 26 years at University of Chicago, it's like this was part and parcel of that particular lab is doing pre-op stress testing. Well, what is the data? So first of all, the big shock, first rule of Fight Club is you don't talk about Fight Club, right? But what happens inside the room stays inside the room. But I'll just be open and admit that when we were looking at electrocardiograms and the recommendation was coming up that maybe we were doing too many electrocardiograms, I was one of the folks who were saying, come on, this is just the way we do it. But that is not the way we do medicine. We morph as the data morphs. And the fact of the matter is that if a person has known coronary heart disease, significant arrhythmias, cerebrovascular disease, et cetera, those people who are at high risk or going high risk surgery should get an electrocardiogram. It's reasonable to do it. It's not a must, but it's a probably, okay? If you have something with a perioperative ECG abnormality that's new, then further evaluation should be undertaken. But class 2B would be to actually do a pre-op 12-lead EKG just because they're undergoing an elevated risk surgery. And the real shocker was the class 3 no benefit for people undergoing low-risk surgery and doing no preoperative EKGs, not recommended. There's no data that it improves outcomes. So the bottom line is that if you want to manage optimally symptomatic or unstable patients, obviously you do an EKG, but there's no proven value in the literature to support my position that we should continue doing ECG. So it is out of the guidelines if a person is not at high risk, personally or surgically. Evaluation of ventricular function, a little less common than EKGs, but if a person has heart failure, that certainly is a class 1. If a person has worsening symptoms, it really would be reasonable to do it as well. But asymptomatic people doing ventricular function studies is really not indicated. And so the presence of either systolic or diastolic dysfunction actually does predict cardiac events. So we try to do this with people who have an elevated BNP or a history of LV dysfunction, but people who are asymptomatic, particularly with low-risk surgery, should not be doing LV function testing. How about stress testing? So this is an area where there basically are no class 1 recommendations that we could defend based on all of the data that we've collected. And but if a person is undergoing elevated risk surgery and they're personally at elevated risk for cardiovascular events based on the risk assessment tool, then you could do stress testing, but it's to be or not to be. In terms of it's something that you could consider. It's not necessarily recommended. If you're at low risk, absolutely not. That would be a no benefit. And so there's a table, there are several slides I'm going to show you just so you know what's in the guidelines, but I won't talk about them. This is one of them that most people know, the contraindications to stress testing. To summarize that one, the issue, why it fell sort of in importance over the years is that we really do a good job of assessing people with poor functional status because you can't tell from their symptoms if they're not moving around well. So a stress test might be helpful there. But reversible myocardial ischemia on a pre-op stress test has a very low positive predictive value for what's going to happen in the OR or in the perioperative period. And further, what are you going to do with the information? We used to always say, oh, if the stress test shows prohibitive risk, we're going to go forward with some kind of revascularization. And we still do invasive angiography for really high-risk features. But what is the data on that? It's actually pretty small. In terms of the preoperative stress modality selection, if we look at our best images now, they really are CT, MR, positron emission tomography. We don't have enough data on those yet to say if they're going to impact care very, very much. But so we still use a lot of vasodilator pharmacologic stress testing with microperfusion imaging. If a person can exercise, please exercise them because you get more information about their cardiopulmonary fitness. And cardiopulmonary exercise testing is actually a really good way to risk stratify people who are at high risk. What are we looking for on the perfusion images? The really prohibitive risk of moderate to large reversible perfusion defects, high-risk findings, and showing you one from the ancient past that we published, showing up of the right ventricle because that person developed pulmonary hypertension during the stress test, including transient ischemic dilation of the ventricle. We don't see those things very often, but they can, when abnormal, predict events, just not very well. However, a normal test does indicate a very low risk, and that's very helpful. Taking over a lot of what we do in coronary artery disease is coronary CT angiography. That still doesn't have a class 1 recommendation, but it's a validated tool, but no benefit, again, if the patient is at low risk. For preoperative CTA, we do know very clearly that if a person is having a chest pain syndrome, that this is a test that really can risk stratify them. The main thing we want to know is how much left main disease, if any, that they have. And we have from this test, because we're able to see the arteries themselves and see what kind of plaque is inside those arteries, it may have a low positive predictive value, but it has a very negative, a very excellent negative predictive value, particularly of a 0 calcium score. There is data on the perioperative evaluation. The risk estimation is actually with CTA so far is marginally improving over the clinical risk score that we're touting. For invasive coronary angiography, this is something we used to do. We're hopefully doing it less because there is no good data that it's of benefit whatsoever. Refer you to the CARP trial that clearly showed that coronary revascularization does not alter significantly long-term outcomes. This is something that that sort of doubles down on what we found many years later with the ischemia trial, that if it wasn't left main disease and maybe proximal left anterior descending in a stable patient, there was probably no benefit to doing all the stents and revascularizations that we were doing. Okay, so drum roll. Everyone is always wants the big algorithm, right? For what we're going to do. This is what it looks like. Obviously, that's not going to work in a grand round, so I'm going to zoom it up a bit. Okay. And so we start off just as you would imagine. We have a person who's scheduled for non-cardiac surgery. And if they don't have, if they don't having, can I move this out of the way so everybody can see it? Because I don't think people can see the top of it. Right?
You can drag it to the bottom.
Yeah,
all the slides were hard to see.
There you go. Yeah. Most of them it didn't matter, but this one it does. Okay, so the people who are felt to be at risk, cardiovascular risk factors, disease, or symptoms, if they're low-risk patients, you just go to surgery. If they are at risk, then you really want to do emergency surgery. Or if it's emergency surgery, then you go ahead and do those cases without further evaluation. If not, then you have some time to think. Does the patient have an unstable, untreated coronary or cardiac syndrome or decompensated heart failure? If so, you start managing that before you send them to the OR. Excuse me. If they don't, then you use your risk calculator. And if they are found to be at elevated risk, then slide this up. If they are found to be at elevated risk, then you can consider doing an evaluation with the 12-lead EKG. You could actually consider doing enzymes or biomarkers. If all of those, if your risk is considered to be low, you proceed to surgery. And you would consider team-based evaluation. That is, get together with the surgeon, talk about the timing of surgery. See? And, okay. This is a tough one. Okay, how about over there? All right. Okay, so if a patient has a poor functional capacity, or has a good functional capacity, go on to surgery. If they actually have a poor capacity, then you would actually think about doing further testing, particularly with the biomarkers. If they're normal, you can proceed to surgery. If they're abnormal, have another discussion about doing further evaluation. So what are you really getting from this? Is way down the list to start doing imaging. Way different than what we've done in the past. And a lot of that was defensive medicine. A lot of it was just trying to make sure that the patient got the best possible evaluation, but the value of it was relatively limited. And so you end up with a lot of 2B recommendations. If a person goes through surgery with all the elevated risk and ends up in this box on the bottom right, that's when you would consider doing post-operative troponin surveillance to find out what happens, because we do have data on myocardial ischemic events that happen in that setting. So we're going to talk a little bit about the perioperative management. There are some issues that we would like to remember. Number one, with a class 1 recommendation, is deferring the surgery if a person is having an acute coronary syndrome. It's better to do the coronary revascularization, and hopefully deferring the surgery is not going to put their life at risk. If it is, then obviously it's urgent, you have to go. With chronic coronary disease, unless it's tight left main, you would not want to try to do a coronary revascularization, as we have mentioned. But without left main coronary artery disease, we would not recommend any revascularization to reduce events. How about blood pressure? This is just an important number to remember, the magic number that seems to correlate with dramatically reduced good outcomes is systolic of 180. Diastolic of 110 has data as well, but the systolic of 180 is a time when you would, when you're consulted, you would want to defer that surgery. Intraoperative blood pressure management, really important to keep it above the systolic above 90, because below that you start to get, in addition to acute kidney injury, you get myocardial injury. In terms of post-op blood pressure, very similar. People who have a systolic less than 90 are going to have more mortality, as well as renal and cerebrovascular and cardiovascular events. And so if a person has hypertension, it's important to continue the medications as soon as they possibly can to try and avoid these situations. For heart failure, one of the important things that came out in this guideline is the data that talks specifically about metabolic acidosis with SGLT2 inhibition. They should be withheld 3 to 4 days. Well, is it 3 or is it 4? Depends on the drug. So you see at the bottom, if it's the more common ones, epagliflozin, dapagliflozin, or canagliflozin, those should be stopped 3, or ertugliflozin at 4 days before scheduled surgery. If a person has compensated heart failure, it's important to continue the rest of the guideline directed management of that heart failure, but excluding the SGLT2 inhibitor. Okay, why is that? This is kind of a stunning table looking at the data very clearly. First, people who have heart failure do badly. Look at the crude mortality with no heart failure versus HFpEF, just from having poor diastolic function. Ejection fraction that's mildly reduced with heart failure, moderately reduced, severely reduced. The numbers just get worse and worse. And so we want to manage them as best we can and keep all the medications except the SGLT2s going. Hypertrophic cardiomyopathy is an important one to understand, that the hemodynamic changes and the catecholamines can actually trigger more dynamic outflow tract obstruction. And I'm going to just mention that we're covering several diseases that I won't talk about today. So they're all a little smaller, but when you pull up the slides, you'll see that we talk about pulmonary hypertension, a lot on adult congenital heart disease, left ventricular assist devices, valvular disease with aortic mitral stenosis and regurgitation, And but I'm going to stop here and talk for a moment about the atrial fibrillation section, just because it's so important to try to manage that anticoagulation and reduce the person's risk of either hemodynamic instability with rapid atrial fibrillation or thrombotic events. And so we have perioperatively good data behind making sure that you don't have any triggers that are contributing to rapid atrial fibrillation, such as anemia, sepsis, or pain before you go to the OR. And if you have new onset atrial fibrillation, it's really important to consider whether or not this person is at high thromboembolic risk, because you do want to do anticoagulation as soon as you can, but not risk the perioperative bleeding. After discharge, really important to follow up these people who have atrial fibrillation that's identified in the setting of non-cardiac surgery. So I won't talk about, just mention the fact that we have a lot of recommendations on implantable devices. But one of them was kind of a small section, but I want to talk about it mostly because they made me write it. And that is reviewing the literature. It only became this one small recommendation. And that is, and it seems to me that it happens every time I'm on service. It's a person with a stroke, and they say, well, we want to get cardiac clearance for a procedure. So what's the data? The data is really bad. That is the biggest risk factor of having a stroke in the perioperative period, having a previous stroke. And there was an American Heart Association, of course, guidance that came out about a year before I was asked to put this part together and review the data. And they came up with saying that it should be 6 months. That was eminence-based, not evidence-based, to be honest. And so that meant I had to go through the whole AHA, getting them to admit that it should be undone. But the bottom line is the risk, excuse me, of a stroke in the perioperative period for non-cardiac surgery probably never goes back to zero. But after 9 months, it tends to flatten out a bit. And the fact is that we've never actually done any kind of intervention. Okay, these folks are going to do 3, these folks are going to do it 6, these are going to do it 9 months. We don't have any data like that. So all you're doing is extrapolation. So all we end up with is a class 2A recommendation is that if you can delay surgery for 3 months after the most recent cerebrovascular events, then please do that. But holding it for 6 months, there's no data that 6 versus 9 versus 12, that it goes down enough after 3 where it's reasonable to go ahead. Perioperative medical therapy, really important. We use a lot of statins, fortunately, because they are really helpful. So you see some big green class 1 indications for people who are on statins to continue in them. And if you have a person who's not on a statin and you're running into them, you're asked to consult, and you do your ASCD risk calculator or the new prevent calculator that includes EGFR and social determinants of health, and you have greater than a 7.5% 10-year risk, and an LDL greater than 70, then it was a good idea to put that person on a statin perioperatively, and with the intention of long-term use. Now, the perioperative renin-angiotensin and aldosterone system inhibitors, you have to be a bit more careful. And that's because you can end up with hypotension that's difficult to deal with. And so we want to do this we want to best manage this by stopping them 24 hours before surgery. And that is actually important. If you have heart failure with reduced ejection fraction, though, you're probably better off continuing them. And so a 2A recommendation to continue it in those particular people. There was a lot of literature that came up about clonidine perioperatively, and it really did not withstand the test of time. You'll see publications actually went back. I was so interested in this, went back to AI to see what Google Gemini would say, and it says it's going to be useful. Bottom line is that's a hallucination. It actually is not beneficial and can result in a lot of hypotension and poor outcomes. Antiplatelet therapy, really important to try to dissect what the patient's risk of bleeding versus clotting and the consequences of delaying surgery. But it's something where you get together with the team and make sure that all factors are on the table before you make a decision. After a percutaneous intervention, whether it's a stent or a balloon angioplasty, really matters. So if it's a balloon angioplasty, class 1 would be a 14-day delay, if you can. If it's a drug-eluting stent placed for an acute coronary syndrome, you really want to do that full year, if you can. If it's a drug-eluting stent placed for chronic coronary disease, then it's reasonable to delay 4 or 6 months if you actually can do that, depending on what the surgical condition is. Now, obviously, there are people where it's a little more urgent, and so you are going to have to go ahead with holding, depending on the risk of surgery, surgical bleeding, holding the antiplatelet therapy, but you want to try to interrupt as little as possible if you can in a person who has a drug-eluting stent. If it's one of the newer ones, the 3rd generation, 3 months may be enough to lower that person's risk of intra-stent thrombosis. And so to be considered would be interruption of one or more of those antiplatelet agents if it's more than 3 months after a drug-eluting stent. With a bare metal stent, which is often what we used to do, oh, this person needs surgery, we're going to do a bare metal stent. We're risking down the road restenosis, so we don't really like to do that. And we try not to stop the antiplatelet therapy less than 30 days because that is associated with more stent thrombosis and ischemic complications. The perioperative management of antiplatelet therapy, basically you restart them as soon as you possibly can in a person who has been stented. That would be a class 1 recommendation. And continue the dual antiplatelet therapy unless the risk of bleeding outweighs any potential benefit. When you have oral anticoagulation, you really want to stop those and use the aspirin whenever you can. That would be a class 1 recommendation in a person who has had a stent placed or percutaneous intervention. If they have a high thrombotic risk, that's when you would actually consider using intravenous antiplatelet therapy. And if you're within 6 months of a drug-eluting stent or 30 days of a bare metal stent, if the surgery cannot be rescheduled or delayed. Perioperatively, the management of patients without prior PCI is obviously of concern to us because you don't want to enhance the bleeding. You have to understand that that there are some surgeons in some situations where they're fine with antiplatelet drugs, particularly vascular surgeons, and others like neurosurgery, spine surgery, don't want anything that's going to increase the bleeding in that particular area. So we're actually very, very careful. Reasonable continue in selected patients and then others. Again, that's probably another place where we could have talked about multidisciplinary discussions to make sure that the surgeon is comfortable. And we generally do that. We write that if you feel like the bleeding risk is not a major issue. No benefit would be particularly if it's someone who's not undergoing carotid surgery. Routine initiation of aspirin without a prior PCI is not helpful. There's data in the guidelines just to remind you what the half-life or the effective life of the antiplatelet drugs are. And so the shortest really being aspirin a little bit and ticagrelor or Brilinta. So there's a nice algorithm that people can use that I'll just throw up so that people can actually see it, making sure that you have a quick and easy access to that idea of balloon angioplasty, 14 days, bare metal stent, 30 days, and the like, acute coronary syndrome a year. That's one to remember. We have a lot of data and recommendations about oral anticoagulation, and I'm putting them here so that you know where they are in the slides because it's really nice to be able to refer to them, but I won't talk about it other than mentioning that we have a really nice table that will tell you sort of the bleeding risk that we've been talking about. If a person has minimal risk, then you're actually no reason to do an interruption. So you'll see green all the way across for every particular drug, okay? But remember that if a person is at high risk of bleeding, you want to stop it sooner and avoid restarting it longer. And that's what the darker brown is all about here. Low to moderate risk, then you can actually shorten that little duration of where you stopped it and restart it. Same is true of warfarin. Hopefully we don't use that nearly as much. Again, having it continue during for people who are at minimal risk is not a bad idea. And so there's a nice table that summarizes it for the mechanical valves, atrial fibrillation, VTE, and that really is hopefully helpful for each risk category of low, moderate, and high risk for bleeding or thrombosis. Really important data that people can refer to the guidelines for the pharmacokinetic characteristics for each of the anticoagulants. A nice table there. Beta blockers is a major thing because it was one of those issues that happened in life where there was a major push for beta blockers based on data that was actually fraudulent. And I won't mention Don Polderman's or all that stuff from 10 years ago, but bottom line is that beta blockers that are instituted to try to protect the patient from something, if there's a new indication for beta blockade, excuse me, you want to start it far enough before surgery that you're not going to end up with the hypotension, the bradycardia, and even the increased stroke risk. And so you do this optimally 7 days before the surgery. If people are on stable doses of beta blocker, go ahead and continue it. It might be for aortic aneurysm, it might be for supraventricular tachycardia. No sense in worrying about that if they're stably on the drug, but we don't add them. That's a class 3 harm. Unless it was something that's absolutely immediate, like a supraventricular tachycardia, then AVNRT, and the person's got a heart rate of 150 and they're unstable. If it's not that, we really should not be starting beta blockers. Certainly not with the idea that it's going to protect the patient perioperatively, because that data was actually completely incorrect. Managing blood glucose is important because of the bad outcomes that happen if the blood sugar gets really high. But just a reminder that we'd want to stop the SGLT2s at least 3 to 4 days ahead of time. I want to show you that there is a section about anesthesia, and just so you know where it is, it's not something that we really normally recommend. Tell the anesthesia people how to do anesthesia. They really don't like that. Funny thing is, we used to do it all the time, and so we want a TEE and a SWAN and intravenous nitroglycerin, and they really took exception to that. But working with them, if you have concerns, that's certainly perfectly fair. Really important to do pain management, so there's a section on that. But I am going to pause for a second from showing to really talking about the recommendation for intraoperative echocardiography and focus. That is, having the ability to do point of care cardiac ultrasound is important because it's a big advancement to determine the cause, particularly if someone is unstable, hypotensive. You want to know if there's anything from hypovolemia to a tamponade. This is a class 2 recommendation. If there isn't any significant hemodynamic compromise, there really is no value. And so we have that as the no benefit. But we have a section on body temperature for those of you who are interested, and mechanical circulatory support, our old favorite, which is no longer a favorite, pulmonary artery catheters, and anemia management. I will talk a little bit more detail for a couple of minutes about myocardial injury after non-cardiac surgery, so-called MINS now. And fact is that if a person actually is at high risk, particularly age over 65, multiple cardiac risk factors, it may be reasonable to measure troponin 24 to 48 hours. We rarely do this, but if we're really concerned about the person, say they had ST segment depression or something on the pre-op EKG, known multivessel disease, then it's not unreasonable to do this. Why? Excuse me. Why? Because if you identify the people who are having active ischemia postoperatively, you can ultimately intervene and hopefully get a better outcome. But doing this in people who are just routinely doing cardiac troponin levels is not of any benefit. You're going to see a lot of positives, the so-called troponinomas, that are not particularly meaningful. But if a patient does develop myocardial ischemia for non-cardiac surgery, they are at increased risk. We want to make sure that that person follows up and gets the full evaluation of their ischemia and full medical management, including antithrombotic therapy. But obviously, you're really making sure that you're doing that at a time that's not going to increase their bleeding. How about the person that doesn't, it's not just a troponin leak, it's actually ST segment elevation myocardial infarction. It still does happen, it happens way less now because cardiac anesthesia is so much more careful than they were back, say, 30 years ago. But these are people who were going to just kind of have a good discussion about balancing bleeding and thrombotic risk and make sure that that person gets full guideline directed management of the ST segment elevation myocardial infarction. In STEMI, similarly, you want to make sure that you take into account the surgical situation and whether or not the bleeding is going to happen with the antithrombotic therapy that's the cornerstone of management of an acute coronary syndrome. It's really important that we consider for an interventional cardiology, an invasive coronary angiogram, again, bleeding, the balancing, bleeding and thrombotic risk have to be balanced in these patients. And if it's a small myocardial infarction, you may want to manage that medically to avoid the surgical bleeding. So we're up to the top take-home messages. And these are hopefully what everyone will sort of put on on their phone and just sort of read through them again, because I'm obviously going through a lot of data and a lot of sections very quickly. But this would really be the bottom line of all those 18 months we sat around trying to put all this data together. Stepwise approach, perioperative cardiac assessment is really important about when surgery should proceed or put a pause in and do further evaluation. The cardiovascular screening for non-cardiac surgery should have the same indications that we would do if the person was not going to have surgery. We don't do extra stuff because they're going to have the surgery. We avoid delays that way and avoid over-screening and over-treatment. Stress testing and my friendly electrocardiogram should be performed judiciously in patients who are undergoing non-cardiac surgery, especially those who are at lower risk, particularly if they're having low-risk surgery. And we would only do them in whom testing would be appropriate and independent of their planned surgery. We try to emphasize team-based care whenever we can when things are complex or difficult, such as sitting with the neurosurgeons about that intracranial bleed and they have an indication for going to the cath lab. We have to have good discussions and team-based care. New therapies for the management of diabetes and heart failure have really important, significant perioperative implications, particularly SGLT2s. Stopping them 3 to 4 days before the surgery so you don't end up with ketoacidosis. The MINS, myocardial injury after non-cardiac surgery, newly identified disease process that has real consequences. We're not going to ignore them. We take our highest risk patients, do the troponin because you think they're at risk. And when you find this, then you institute guideline-directed medical management. In patients with new onset of atrial fibrillation, we were always thinking that perioperative atrial fibrillation is just not that important. They really should be fully evaluated to see how important it is, including long-term monitoring after discharge to see if they have a significant atrial fibrillation burden and was going to need part of our new treatment. It might be a Watchman, it might be pulmonary vein isolation. We have so many techniques in electrophysiology these days that long-term rate and rhythm control and anticoagulation and what's appropriate for that patient needs to be assessed. Perioperative bridging of oral anticoagulation. Didn't talk about too much other than to say that we find a lot of bleeding when we try to bridge. And so we use it very selectively in people at the highest risk of clotting, such as a mitral valve that's mechanical, as opposed to an aortic valve, which you have a little bit more leeway. But for most cases, we're not going to do bridging. In people, lastly, in people who are hemodynamically unstable, we can do emergency focused ultrasound. It's really helpful to understand what's going on with the patient for preoperative or perioperative or intraoperative evaluation of the patient. But it really shouldn't replace a full blown echocardiogram. And with that, that is the end of those recommendations. And I just wanted to leave 5 minutes. Oh, looks like I left 6. Okay. All right. Thank you very much. And again, I appreciate everybody. And hopefully people will come and get the slides or download them online. Important document, changes a lot of things and how we look at management of a lot of conditions in the perioperative period. Okay, so any questions? Okay. Yes.
Does the criteria, the guideline talk about pulmonary hypertension? Unless I missed it, but I'm
Yeah.
not sure.
Yeah, it's one of the ones that I went through really quickly. If I can, that was the whole point of putting it up there in case people wanted to ask specific questions about it. And I will find it. I'm sorry, but did you have a specific question?
Yeah, I mean, I understand the risk like with pulmonary hypertension for like the preoperative risk. That has to do, for example, if only they have like heart failure, like right heart failure, for example, or service by itself, regardless of heart failure.
A really important question. That is, these people are at extremely high risk. They come in a lot of times with right heart failure and volume overload, and when you diurese them, they can get hypotensive and die. And so if they're on a stable therapy, you try to make sure that you continue the agent. That's really the guideline recommendation for the pulmonary hypertension. There's a whole section about the nitric oxide mediators, endothelin receptor agonist, prostacyclin. And keeping these people stable is not easy. It's a very sensitive issue. It has affected so many of us and so many of our patients. So, but the important thing is to make sure they're stable before you start to do particularly elective non-cardiac surgery. Okay, if a person's having fluid right heart failure, they're going to need that balance of diuresis and avoiding hypotension, and that should be done preoperatively. Not easy.
Yeah, I was gonna say, a lot of the times for us as the hospitals, and you guys probably too as a cardiologist, we get the question at 8 o'clock in the morning of an elderly patient who had a fall probably related to frailty, and they're asking us for cardiac evaluation. And it sounds like based on this, that there's not a lot of reasons to delay surgery unless they're in some kind of acute cardiac event. But what would be the utility of maybe checking an echocardiogram afterwards? Like if I'm worried that maybe the patient has a dilated LV or so, they're not presenting in overwhelming fluid overload, they're not presenting in acute heart failure. But would it be reasonable to know that for risk stratification after the surgery?
So that's a really good question. The important part is that we don't have a lot of data on, I showed you the data on how bad it was to be frail. What we don't have is, okay, the person's frail, what do we do now? You're not going to just, give them an unfrail pill. I wish we could. But what we can do is recognize that that person is going to be moving around less, so much higher risk of getting venous thromboembolic disease and pulmonary embolism and dying, and as well as their tissue recovery, their nutrition. All of those things are going to put the increase for postoperative and perioperative problems. So the main reason to use that frailty score really is to make sure that the surgeons and the anesthesiologists know that this patient is at extremely high risk. Whether or not you use an echo, I would have to have something that was pushing me toward it. If the patient can't express dyspnea, but they're tachypnic, or the oxygen saturation is low, then I definitely would use the imaging. Yeah.
So question about atrial fibrillation, and if it's new AFib, I know that we don't necessarily want to start somebody on a beta blocker if they hadn't been on one. if we can avoid it. So how would you approach that if you had a patient who had new onset AFib, maybe needed some sort of, maybe they were in RVR, needed
Mhm.
something, would you go ahead and start the beta blocker? Would you put them on amio?
So actually, we try to use the beta blocker nice and easy when there's blood pressure to burn. Okay, so no problem. And if that's the situation, it is more than reasonable to go ahead and use the beta blocker, even though you've got this stuff in the back end of the POISE trial, POISE 2 trial, there was increased strokes, hypotension, AV block, and death. Other than that, it was no problem. And so we don't do it unnecessarily, but getting rid of a rapid ventricular response and giving the diastolic filling time for the heart is so important that we take the risk of a beta blocker being used acutely in order to treat that. Now, obviously, if you could wait 7 days after that to make sure the patient's stable, but usually you can't wait 7 days. And so the person is going to rapid AFib for a reason. So you look for whatever that reason is, see if that's correctable. And if the patient starts getting hypotensive, that's the beauty of amiodarone. It doesn't cause as much hypotensive. We have to be respectful of what amio can do when a person has heart failure and low ejection fraction. Long term improves their ejection fraction. Short term, you can get some hypotension. So we're careful with amiodarone, but the beta blocker I would not be afraid of if the patient's got enough blood pressure. Yes, sir.
My question is about a particular patient scenario for those that you would check troponin 24 or 48 hours. I think it was a 2B recommendation. If I'm the cardiologist seeing the patient, can you give me the profile of this patient? Is it a clinical assessment after surgery that, you know, he's saying chest pain or she's complaining of new shortness of breath? Or is it more of, well, this patient has a lot of risk factor for coronary artery disease. Is it a chance for me to identify that then and there? And yeah.
You did that really well. So the answer is to replay exactly what you just said. Okay. The only thing I would add is that sometimes people will see on a monitor, true or not true, ST segment changes. And that could trigger an electrocardiogram. If you have new EKG changes, it's probably worth it. I'd say but add to that everything that you said. The people who are at high risk, they got a CAT scan of their chest preoperatively for that thoracic aorta. You saw that calcium was everywhere. It's multivessel. It's in the left main. Then you're really tempted to follow those enzymes perioperatively. Another one that we don't often think of is someone whose creatinine is going up. And it makes you go back and check the anesthesia record, and you see that for 20 minutes, the systolic was 70. And so they got an AKI. That one you might want to do as well if they have known coronary disease, particularly because they might have cerebrovascular, cardiac, as well as renal.
And one last question and maybe a comment. Congratulations first on a very, very comprehensive, extensive guideline. One of the troubles I've always had with teaching our trainees, especially about scores, and I love the fact that, you know, this document says use a standardized score, is the entry point into RCRI doesn't really, for a lot of trainees, they don't think about asking about physical activity. Because they just focus on, is there diabetes, is there CAD, is there CHF, and it stops there. And so you could be, just like Dr. Brown mentioned, have a 98-year-old woman who's never moved, been in bed for 6 months, and there are no overt signs of heart failure. And because there's no history, there's no known coronary disease, cerebrovascular disease, etc. It could all be lurking under the surface. So, you know, I love the fact that this document put DAISY in there. You need some assessment of physical activity to even enter the RCRI.
Exactly.
That was my comment. But the question is more about, you know, the document is de-emphasized, and maybe rightfully so, moving away from extensive testing. But I want to get your sense on that requires great physical exam and comprehensive capabilities for assessing the patient in totality. For example, this woman that I talked about who's 98, she may have a carotid bruit, a renal bruit, peripheral vascular disease, hasn't moved, has heart failure, but now is dehydrated because she's in bed. It gets to be really complicated to say, okay, don't do an EKG because we don't have the data, or don't do an echo because we don't have the data. A lot of this is the data doesn't exist because the appropriate trials have not been done. So I hope this is a moving living document that as more data comes out, we tend to be more aggressive in determining if they have cardiovascular disease, not necessarily stenting or revascularizing them. So I want to get your thoughts on that because the document has not moved much over the past 10 years, aside from saying, we de-emphasize certain things like don't do an EKG.
Great. So very well stated. And yes, absence of proof is not proof of absence. Well stated. But I would say that we do have data that says that, the coronary revascularization, and therefore we assume the carotid and if you've got a renal bruit, that revascularization in the perioperative period isn't really indicated. We don't have data to support it. However, in terms of the person having a poor functional status, certainly right, using the scoring system, using DAISY will be informative that the patient is at high risk. And I would say that physical exam, you're absolutely right, we underutilize it. And a person, if they have a renal bruit, abdominal bruit, the odds of them having significant obstructive coronary artery disease is above 70% right there. And so I think that would trigger an evaluation. Now, the question is, what is that evaluation? Probably the EKG, probably not the stress test unless the patient is having active symptoms. All right.